Okay, good morning everyone. Thank you for attending. If you heard my talk on, who heard my talk on Wednesday? Okay. I'm going to try to recap a few points on Wednesday. I'm not going to get too much into detail. If I have time at the end, I'll try to recap more in depth. On Wednesday, what I tried to cover was how to see differently, understanding long-term ideas of fat grafting and safety. I'm going to address a very, very small part of that this morning. I'm going to principally talk about how to do it. And I think as surgeons, in order to understand how to do it, you have to have video. So this course is about half video. All this video is original. You're the first people to see it other than myself. So this is actually for a book that I wrote about 1.5 years ago but never came out just yet, so you'll be the first people seeing it. And so I want to talk first about how to see, because if you don't understand how to see, you cannot transplant someone. Can everyone hear me okay? Yeah? Okay. So if you look at Sharon Stone from her 20s to her 40s and you ask again here, how is she aged? We look at this and we think it's totally gravity. But if you look at the brows, you actually see that this height is almost the same as this height, if not maybe even slightly higher. This one is almost the same height. And the skin may have come down about 1 millimeter here, but it's actually gone up maybe about 1 or 2 millimeters here. So what we think is gravitational is absolutely, in my opinion, not. It's just hollowness. There's more bone. And if you start to compare old photographs of a patient, you'll start to see that the brows have not fallen in the majority of patients. It's just become flatter and hollower. So what looks like you need a brow lift, you need a facelift, you don't really, in almost 98% of cases. So this is a reductionist model to help communicate. I'm always into not only communicating with you as physicians, but also with your patients, right? Because your patients have to understand this. So I always say when you're young, you're a grape. As you get older, you become a raisin. But why should you take that raisin and pull and cut and stretch it into a pea? Because I always say a pea does not look like a grape. A grape looks like a grape. So in other words, people are not looking like themselves after extensive lifting procedures. So we have to take a step back and wonder, are we doing the right thing? And the best way to convince you, because you have to be convinced before you can convince a patient of this, right? Because if you don't believe in it, a patient won't either. So take a step back and help a patient understand this. Ask them to go back and look at the old photos. Yes, sir?
Good morning.
Good morning.
To interrupt that earlier. It's a very strong call in here. Could you try to get it a little bit away?
Yes.
Maybe we will have difficulties after an hour.
The sound. Yeah, I figure I heard a little, thank you. Let's try this. It was up here to begin with. Is this better? Thank you, thank you. I heard that too. I was wondering about that. I appreciate your input. Any other feedback, please let me know. So is this what we want, a baby face? No, it's not what we want. So understand, oh, sorry, hit the wrong button. Understand that the way to look at aging is fat loss from birth to death. That's it. It's very simple. Yes, we accumulate rhytids, we accumulate maybe some gravity of the neck, maybe some other changes, hair loss, skin changes. But principally, the mechanism of global facial aging is volumetric collapse. And if you think about it, if I ask most women when they like themselves the most, men can be a little later in age, women usually tell me around 30 to 32, not 20 to 21, because there's a lot of baby fat on the face. And so it's a linear loss of fat. So baby fat isn't a unique entity, it's just loss of fat from birth to death. So you saw this on Wednesday for those that attended, is a new paradigm of understanding aging from volume changes. So when you look at a 10-year-old, a 20-year-old, you instantaneously can see how their ages based on the shape of their face. They go from a full circle, and that circle eventually becomes a triangle, and then as we start to lose volume and the lower face starts to dominate, perhaps with some metabolic changes as we gain some weight in the lower face, we start to become more square, and then the triangle starts to invert. So the question is, where is the perfect age? Is it a 20-year-old face? And remember, you're trying to take care of the patient, and most patients don't want to look round. So it's actually probably around 30, and it's a concept I like to think of as an oval. The ovalization of the face, to me, is perhaps the most attractive, which is 30 to 32. And if women go back and look at that, they see that. Men sometimes a little bit older. Men sometimes look better with some wrinkles and a little bit of volume loss. Okay, so let's start with, to me, probably the most important area in terms of volume. It's probably the easiest area to do as well, is the cheek. The cheek, to me, is divided into two areas, and we'll go into more specifics in a moment. The anterior cheek is where the malar ligament is, the anterior depression, and the outer cheek, the lateral cheek. Those are the two components of the cheek. But as we go also down, there's a buccal component as well. And that buccal component is part of the cheek. If you just build the cheek up and you don't build the buccal area and select patients, and we'll talk about patient selection in a moment, then you're going to have too big a cheek. It won't blend and balance. So the art of a fat transfer is not just targeting one or two areas. It's targeting multiple areas so that you create overall balance to the face. And then this is what I call the upside down U, a terminology I came up with to explain to patients, because most times when people are looking at the lower face, they're focused on a mandibular, they're looking at a marionette line or a jowl. But what I want you to do today is to teach you to see negative space, something that's absent. So what I see is that the chin starts to stick out as we get older, and the anterior chin starts to hollow out. And I'm not just talking about the mental sulcus. It's not lines. We're too fixated on folds and lines and things. We're talking about an absence of tissue where the bone begins exposed here, and also right in the pre-jowl sulcus. So this continuum of a U, to me, is very important, because overall what it does, when you fill all those little components, you create an overall oval. And what you may have heard me say on Wednesday was a concept of blink. There was a book by Malcolm Gladwell, which is, we judge each other instantaneously in a blink. So my goal is to help people see each other look better at 5, 10, 20 feet away instantaneously. You can look at that person and say, wow, they look good. That's the blink, and that's by creating improvements in multiple small areas of the face. So then overall, for this 49-year-old lady, you can create a lot of small changes that look better. Okay. Let's go back and focus on the buccal again. Is it just putting it right in the center? No. Well, the most obvious is the center area where there's a central depression. But the buccal area is more complex. I usually look at it in about 85 to 90% of people as what I call two thumbprints, which is when you start to look at people in a three-quarter view, you can almost take two fingers and put it right here. There's one in the center, and there's one right below the zygomatic arch across here. And those are the two areas I tend to target, with the principal area being the center, and then a little bit more toward the side as well. Those are the two areas that almost everyone universally could benefit a little bit. Not everyone, but most people. And then a third area is toward this where the loss of dentition. If someone is losing a lot of teeth as they're getting older, the maxilla is being lost. There's a little soft tissue hollowness here, as well as for someone over 60 that maybe doesn't have great dental hygiene. And so there are three components. I call it the medial buccal hollow. These are just my terms that I've come up with as I began to see. So this lady here is 16 months after a single session of fat transfer. She had fat grafting into the brow upper eyelid, which we'll talk about more in a moment, the lower eyelid tear trough, the anterior cheek in a confluence to the central buccal area. Her outer cheekbone I blended and covered, and I went underneath the arch of the zygomatic region as well to blend that in. The anterior chin, you can see that upside down U of vacuousness sort of arching across. I'm so sorry, the photos are hard to see here. At the end, if you want to come up and see my photos, I'm sorry, it's a little dim. I can really see it well here, but somehow it's not picking up too well there. So it's across the anterior chin, really helps a lot to blend it in. And also, I believe that fat is not an effective instrument to fix the folds very, very effectively, but it's an area that, in her case, seemed to help a little bit. Again, I'm sorry the photos are not turning up as well as I would like. That one's a little bit better. Okay, so this lady had multiple small procedures done. We'll talk more about what they are in the context of the eye. But in the buccal area, she's actually quite wide, so you want to be really careful in the buccal zone. I put a drop, maybe less than a cc, into the central buccal zone so it blends the cheek into the fuller lower face. And again, anterior chin work to almost draw the face forward. So this is a very, very conservative buccal treatment. This lady had no buccal treatment, and so it looks like I did liposuction or a facelift, and I did not. I added volume to the anterior chin, the upside down U, and the central anterior cheek. Nothing on the outer cheek, nothing in the buccal. And what that's doing is it's creating an illusion of drawing your eye forward to actually narrow the face. And so that's part of the art of understanding it. What is so important is the eye, because framing the eye is the antithesis of what we used to think about the eyelid. Blepharoplasty, brow lifts, blepharoplasty, brow lifts over and over and over again. But it's the opposite. It's framing it back in with volumes, thinking of it again in a negative space connotation. So let's take this example again. Oh, sorry, we'll go back. If you look at her, it looks like she's got an eye bag, right, or steatoblepharon. No, I just added fat to the lower eyelid, and I took a little bit of skin from the upper eyelid, but I filled it in. So I filled it in, and that's the goal of filling that eye in instead of cutting on it. This is an eye that looks like this bug eye, very, very large eye. And what are you going to do? Are you going to do a blepharoplasty on this? Are you going to lift the brows? No, she would look worse. So this is actually squeezing the eye down and framing it. Whereas what I believe is as we get older, our eyes actually become more vertical oriented, becomes more open and wide, almost like a cat eye like this. And what I do instead is reconfigure it to a horizontal, longer eye. Again, if this makes no sense to you, go back and look at photos of yourself or of your patients in youth, and you'll see that their eyes in youth are longer and narrower. As we get older, they become wider and gaunter and flatter. So that's just a different way of seeing it. So this lady, for her eye, I took a little bit of upper eyelid skin removal, did a transconjunctival lower blepharoplasty, some plasma skin resurfacing, some Botox, and fat transfer around the eye. So multiple small things. But I look at the blepharoplasty as an adjunct, not as a principal mechanism to rejuvenate the eye. Almost everyone gets fat grafting, and a few get some lower eyelid work and some get some upper eyelid work, but on the order of being maybe less than 20%. Here's a lady at 41 who's already had an upper eyelid blepharoplasty, brow lift, lower eyelid, and everything is empty, and she looks hollow. So this is adding fat back into the eyes and bringing the brow lower, bringing the upper eyelid and lowering it to frame the eye, and once again creating a nice horizontal, longer eyelid configuration versus vertical. So, framing the eye. Let's talk more specifically. What does this technically mean? So let's focus down on the eye and break it down to its subcomponents. And again, I'm going to show you this in video format. So first, tear trough, lower eyelid, we all know this. This is probably one of the most important areas to fill and make that look better. The reason I divide the lower eyelid into two major zones is that a lot of times, especially in people in their mid-30s, early 40s, they don't have much hollow going laterally. It's more centrally here, so I put different volumes in. By compartmentalizing the lower eyelid into two zones, it's easier for me to visualize and to inject the fat. Then the area of just sort of a greater soft tissue loss that's a little bit inferior to this, the nasojugal groove, is an area that I put a little fat into, not much. I actually put in probably less than 1 cc. You're going to hear me talk a lot about volumes that are much more conservative than what you're going to hear other speakers talk about. Does that make me right? No, it doesn't make me right. This is how I put it in. I really believe very conservative amounts of fat placed over multiple small areas creates an overall effect that's very, very attractive. And then this is so important. When I started my practice doing lower eyelids, I didn't do a lot of lateral canthus, and I started to see these hollow dips out here, and I missed it. So you need to go out there and independently, we'll talk about what that means technically in a moment, how to inject laterally here to help with this depression. You got to go as a separate incision to enter this lateral canthus. And then the upper eyelid, the lateral brow. If you don't understand this, I always say consult some real good textbooks on plastic surgery. Here, write them down. They're called Vogue magazine, Glamour, Allure. Because the joke about this is if you look at plastic surgery websites and textbooks, they all look ridiculous because we're missing what a young woman looks like. they look like ones in magazines because they're the ones that's a youthful configuration. So the goal is to understand that outer brow convexity. It's a gorgeous look when you fill it in. And then as we get older, what is called an A-frame deformity, because it looks like an A. You start to hollow here, especially with aggressive blepharoplasties. You start to lose volume immediately. So the goal is to fill that back in and fill fat in, and you can all do this through one entry point. And then this sort of confluence of the brow upper eyelid, where I'm looking at it and I can see that dip of the orbital rim. So I'm filling it over the upper eyelid brow complex and then into the dip of the bone going in. So that confluence there is important. And then a small modification I've made over the last year and a half or so is after I finish the whole frame, I see there's still a little point of dip just laterally right here. So I'll go in and put in maybe 0.2, 0.3 cc's, and just so that it blends in nicely from top to bottom frame, so that they blend in nicely.